Welcome everybody to the AMETHIST at Penn March 2024 seminar. We're going to be talking about writing IRB proposals for implementation research. My name is Megan Lane-Fall, and I'm one of the directors of the AMETHIST at Penn Implementation Science Hub. I lead this hub with Rebecca Ham, who's a maternal fetal medicine physician, and I'm going to be your moderator for today. Our panelists are Drs. Amanda Bettencourt and Danielle Cullen, who both are part of our training core in Amethyst and also are implementation scientists who have research portfolios that touch on this space. So I wanted to hand things over to Dr. Bettencourt, if we can start with you. She's going to tell you a little bit about what she does, what her research looks like, and more importantly, kind of what some of the IRB issues that have come up, institutional review board issues that have come up. Dr. Cullen will do the same, and then we'll transition into a robust question and answer period, informed in part by some of the questions that you all have submitted in advance, and then we'll start.
IRB proposals. As Dr. Lane-Fall said, I am an implementation scientist. I'm an assistant professor in the nursing school, and I'm a pediatric clinical nurse specialist. So my clinical background is in kids with burns and trauma. I have several different sort of lines of research going, some in hospital environment and some sort of multi-center implementation trials, if you will. And so I've had a bit of experience in helping the IRB understand this type of research, and also making sure that we're protecting the subjects of research, even when they're not always patients and families, but sometimes they're clinicians. So I made a few sort of slides for us to react to. I guess it's probably good that I'm going first, but I thought I would do some level setting on just the slides for us to react to. I guess it's probably good that I'm going first, but I thought I would do some level setting on just the IRB implementation science and protocols, broadly speaking. As you probably know, the IRB requires you submit a protocol for review if humans are the subjects. And for implementation science research, a lot of the times the humans are clinicians. But also, and probably should, include patients and families. And it's always fascinating to me the way the IRB thinks about clinicians as humans that need to be protected versus how much they scrutinize patients and family data and its protection. And we can talk more about that. I'm sure it's in the questions we've submitted beforehand. So I, generally speaking, when I'm writing a protocol for a research study, I write the protocol as if it will not be exempt and then hope for exempt status. And I'll tell you what that means. So you have to submit the protocol, and then the IRB, based on some criteria, will decide if you get exempt status or not. What exempt means is that the IRB only needs to do an initial review. They don't do ongoing reviews, and you don't have to give them all the information every time you change something about the study. It is separate from a waiver of informed consent, right? So we still, in most of my research, get informed consent from participants when we can. But exempt means basically it doesn't have any more than minimal risk. The participant selection is equitable. There's no coercion of participants. They will be informed, participation is voluntary, and that we've protected the privacy of the people who are going to be in the study. That's the broad criteria, at least that the Penn IRB uses to determine exempt status. Interestingly enough, I've come across in my multi-site research that some places allow individual PIs and clinicians to determine exempt status on their own. And kind of have a checklist and can run that through their own filter, and then not even submit to the IRB if they think that their thing is going to be exempt. So if you're thinking of doing your research outside of the Penn environment, Penn CHOP, Philadelphia bubble, know that there's some variability out there. So some things I think are unique implementation science challenges that I've come across, and I'm wondering if Dr. Cullen and Dr. Lane-Fall have seen these similar things, but typically the things that we're doing in an implementation science research study, the interventions or the different strategies are close to the standard of care, or at least are not violating the standard of care for patients, or what clinicians could be reasonably expected to do as they try to improve care in their clinical environment. So getting exempt status is pretty common, especially if you're looking at, does education help clinicians do this thing more often? Or would giving patients a voice in a particular thing, make them feel more informed and able to participate in care? These are all things that should should happen. And typically we're just trying to support people's best practices anyway. One thing that I don't think IRBs like, at least in my experience with implementation research, we normally are doing mixed methods things or things like implementation mapping, where we're kind of learning as we go what the actual tactics are going to be in our research. They don't really like that. They want to know all of the things you could potentially do, and then decide if any of those things are risky. And so you can't really get away with saying, well, we're not really sure what strategies we're going to test. We're going to do some mapping and figure it out. I find that they really like a very exhaustive list of the options and then telling them what you're going to choose. So it's a bit tricky in implementation science, because these IRBs are looking out for the health and safety and confidentiality of the participants, as they should. So interestingly, I'll say this from an implementation scientist who does a multi-site hybrid trial, and that's funded by the DoD. Most federal funding will say that you should use a single IRB whenever possible. And that's an important thing for clinical trials because it minimizes regulatory burden and all the things. And the best thing about a single IRB structure is you only have to do the IRB one time, your protocol, and get your approval. And then the thing is that the other places that you're doing research with just rely on that single IRB's determination, and you have some letters that go back and forth, and you're all set. What's interesting that I didn't know is that if your study is exempt, which a lot of implementation science research is, you can't use a single IRB structure. So on the one hand, it's great to get exempt status because there's less stuff that you have to do from updating the IRB standpoint. But like in my case, I have 24 hospitals in a research study of mine, and we got exempt status, but the single IRB would have been great. Instead, I have to contend with 24 IRBs who all have different ideas about whether it should be exempt or not. And that caused about a 6-month delay in the launching of my big study of late. So I will say that a single IRB is great, and if you can get one, fantastic. But the problem is, if it's exempt, they won't, at least the Penn IRB will not serve as a single IRB structure for the other places. I mostly say that here. Now, the thing is, implementation science is kind of a new field in healthcare, or at least one that not every hospital is familiar with. And so I also find that single IRB would be great if that IRB is sophisticated enough to understand implementation research. But it's a little bit foreign to a lot of hospitals and IRBs. They don't really know where to situate it because it usually involves clinicians and patients, and it's minimal risk, but also they don't want to expose their institution to anything publicly. So if you end up not having a single IRB, or that single IRB is not very savvy in implementation science, to be very careful how the protocol is written so that anyone can understand very plainly what you're trying to do if they've never heard of implementation science before. And we learned this lesson having to do 24 IRB approvals in my large study. So I say explain everything very clearly. If something is the standard of care, say that. If it's educational, say that. And if there's any risk, say that too. And then also be very mindful of protecting clinician confidentiality and avoiding coercion. Things that they get hung up on with implementation science is randomization. I might randomize how people get education, but education in and of itself is not a risky intervention. And so when they see randomization, they automatically kind of think like, oh no, this is experimental, somebody's not going to get something. And, so you have to be a little bit careful the way you write about it, and making sure that even if you're doing things like randomizing people to get different implementation strategies or whatever, that you're talking about it in a way that ensures the IRB that nobody is getting less than the standard of care, and that these things are not high risk. So last thing I'll touch on, and then I know we're going to have panel time, is the downside of exempt status. I originally was pretty happy of getting exempt status for at least this very large scale thing that I'm doing. And in fact, I think almost every study even at the Children's Hospital, which is a tricky place to get exempt status around here, has been granted exempt status. But then it's sort of on us as people who are doing science to make sure that we're still submitting everything to the IRB. If it's a change, they're more than happy to review stuff, even if they don't have to. So I tend to err on the side of acting like we have to do things and doing them anyway, rather than just assuming I don't have to, or no one else needs to see this new flyer that we're doing, or no one else needs to weigh in on this change we're making to the protocol. I tend to err on the side of just doing that and running it through the IRB anyway. And then I think exempt status is challenging when clinicians are involved, because trust is a big deal. Even in a research that I'm leading these days, where we're interviewing clinicians about something very innocuous, I had many of them reach out to our research team, like outside of their work setting, using a separate email address, totally wanting to make sure that there was no way we would be identifying where they work, so that they would participate in the research, just because I think there's a lot of trust erosion these days among healthcare people in hospitals, and mistrust. And so I work a lot with nurses, and that's a big deal in my profession as well. And coercion can look subtle. If we're asking a nurse manager to email a survey link to their staff and then ask them to participate, that's their boss, is that some form of coercion? So I just think a really important thing for us to remember is that when we write the protocol, we should definitely be very clear about all the things, how much risk there is for all the things in the study, who can benefit, who's burdened by it. And then even if the IRB of record says, you're good to go, run with it, we don't want to hear any more from you, I tend to err on the side of, I'm going to share with you everything we're doing anyway, because I want an extra set of eyes on it, because I think it's just imperative for us to make sure we're protecting clinicians and patients as much as we can, even if the research doesn't feel experimental or high risk, because that's typically the way IRBs deem it. So those are sort of my big points off the top of my head, but certainly happy to share more, and I will stop sharing my screen.
My own work, I'll give you a little bit of an overview of who I am and what I do, and then with a specific proposal and project that we are putting together right now, talk about some of the same IRB considerations and how we're thinking about them and operationalizing them within this work. So I am a pediatric emergency medicine physician over at the Children's Hospital of Philadelphia. You heard about different considerations about risk level when you're thinking about children and caregiver involvement. And my overall goal with my research portfolio is to promote health equity among socially disadvantaged kids through development, testing, and scaling of effective, equitable, and family-centered practices, with an overall goal of reducing unmet social need. So where it is that my work falls right now is in these three different buckets of research programs, and then hopefully elevating those to the level of policy change. Within research, I focus a lot right now on trying to reduce some of these unintended consequences associated especially with social risk screening, assessing for things like food insecurity, housing, transportation in the clinical setting. Acknowledging that while all of the effort around this and mandates and incentives, healthcare institutions now are actually starting to be reimbursed for medical visits only if screening and documentation of social risk is in the child's medical record. While we may think that this is all a moral imperative, what we forget sometimes is that asking families questions about their social risk, especially in front of their children, in front of their healthcare providers, can be associated with some potential for stigma, being viewed or perceived being viewed as not fit to parent their child, or even unintended consequences. At worst, having child protective services involved in their child's medical care, or even having a child removed from the home for issues that are related to poverty and not parenting. So what it is that I do here are large population level studies, randomized control trials, mixed method studies, in order to figure out how it is that we can conduct practices that are effective identifying family prioritized social need, desire for services, and then being able to help families access the types of supports that they want in a way that preserves their autonomy, privacy, and ensures equity. Because as we all know, research takes a while and that can be frustrating, and there are families who could benefit from support right now. I also operate programs, especially around food insecurity in the clinical setting. This is a picture from our Complete Eats program. So it's a partnership with the Nutritional Development Services of the Archdiocese of Philadelphia in order to provide free meals at the point of clinical care and then help families access other resources for food and other services that are closer to them in their communities. So building some positive past experiences so that we can help families develop more connections and leverage the wealth that already exists within the community. Through research and programs, we take what we learn from these evaluations and create policy briefs and statements, meet with policymakers to try to make sure that some of those caregiver-raised concerns as well as preferences are hopefully integrated into policy and practice change. Everything that I do, I like to think that I do it with a lens of community-engaged research as well as implementation science. So let's talk specifically about some work around social risk, social need, social care integration, as I like to call it in the clinical setting. A lot of our work, this family engaged work, builds on previous components that have been established in the literature of what are best practices for how it is that we can assess for and help families address unmet social need from the point of the medical setting. And what it is that we've determined through a line of research studies is that we think that there are these three core components that have been evidence-based for social care integration in the pediatric medical setting. And this is called the SECURE protocol. So socially equitable care by understanding resource engagement, as that acronym SECURE. These three components are first, that there should be an electronic, caregiver-facing and self-administered social needs assessment tool that allows families to prioritize what it is that they want help with without any necessary disclosure of risk that they're experiencing. Second is that there should be electronic resources that are available and loaded onto the caregiver smart devices or sent by email so that caregivers can search for these when it's convenient to them. They're prioritized by what it is that the caregivers say that they want, and that these are also available in the preferred language of the family. And then that there should be an option for individualized resource navigation to provide wraparound support for families in a longitudinal way after the point of the medical visit. So each of these components has been rigorously established in the literature and then enhanced by some family-centered practices and mixed methods work. But the question still remains, how do we actually get this into the clinical environment successfully implemented in order to achieve population-level impact? So we are working right now with the Pediatric Emergency Care Applied Research Network, which is this national network of pediatric emergency departments, in order to determine the strategies that are necessary to integrate and implement this protocol, and then trial that. So overview of the aims here are understand those facilitators and barriers at each of the 6 sites that we're working with for how it is that we could get the SECURE protocol into practice. Aim 2, like Dr. Bettencourt was saying, use that process of implementation mapping in order to match strategies to the facilitators and barriers that we're finding in order to create some sort of generalizable implementation strategy bundle that can be used particularly for this study in emergency departments. And then in Aim 3, conducting a hybrid type 2 effectiveness and implementation trial to see how this implementation strategy bundle contributes to success of implementation and then also health outcomes on the part of the family. So what it is that we're considering in putting this work together is, what does this mean for risk levels for families, and how is it that we could explain this to the IRB? So emphasizing the points that were just made, do we think about this as separate protocols for the different aims? The contextual inquiry in Aim 1 is working with healthcare providers, people who work in the medical space, because we've already collected that family level and community level feedback. Most likely for the IRB, this could be exempt, at worst expedited type research, but most likely exempt. AIM2, implementation mapping, the IRB may not really understand, as you were just hearing about, because this is work group based methods and participatory action work. So would this be deemed as quality improvement and not reviewable, or even anywhere on the spectrum of quality improvement to research? So should these be two separate protocols, only one protocol that combines those two aims? And then something that we've encountered in the past is that in proposing a trial that's based on implementation strategies that you develop, the IRB doesn't want to see it until they know what strategies you're going to use. Because if you can't explain what it is that you're going to be doing in explicit detail, it's hard to understand and it's hard to assess risk. So, so thinking about whether that needs to be a separate protocol that occurs later, or how to provide enough detail to assure that this is all going to be relatively minimal risk. And then in thinking about hybrid trials where you're collecting healthcare utilization data or process data, fidelity outcomes as your implementation outcomes, and then patient level outcomes as your effectiveness outcomes, there may be different classifications of risk associated with each of those co-primary outcomes. And even explaining what it means to have co-primary outcomes can be a little complicated. So thinking about what a consent procedures look like here, if you're implementing a new standard of care, it would be impractical to consent every patient that's going through this process, even though there are some sites that are randomized to not have that implementation process take place. So a lot of complexity that you can see is playing out within this example of a project. Another thing that Dr. Bettencourt was referring to in her project that we're thinking about here as well is that we've arranged this 5-year study so that the first 2 years are dedicated to aims 1 and 2, and then there's some lead time for implementation, and then that hybrid trial happens. But if we can't put forward that hybrid trial IRB proposal until after we're done with implementation mapping, what does it mean for the time course of the study and the importance of timeliness there? And then also with the structure of the multiple different IRBs, what supports should we have in place ahead of time to think about getting exemption, hopefully, from these multiple different IRBs, or thinking about the timeline with which we submit all of these separate protocols, depending on how it is that we're dividing them. So again, I was saying this to Dr. Lane-Fall just before we started this call. I don't think that any of us can pretend to have all of the answers here, but we're all experiencing the same issues. So
first names, if that's okay, because we've used the titles and we all know each other pretty well. I just want to thank you all for introducing your work and some of the considerations that have come up, and I'll highlight some of what I took away from each of your brief presentations. For Amanda, you talked about clinicians versus patients and families as participants, which is really, really key. And one thing that I see missing often from IRB protocols and from grant proposals for that matter is thinking about those different populations of folks, because the risk profile is different and you really do need to cover it for both of them. And I especially see people missing that piece about coercion for employed staff. So it's a really important part. The second thing that Amanda brought up was writing expansive protocols that cover everything that you could possibly do, which is something certainly that I use in my work. Is you don't know exactly what strategy you're going to use, but here's a list of about 20 of them that are likely to show up. So hopefully you don't have to come back and say we used, 3, 5, and 7. You can just say it's in that list. And then another thing that came up a little bit implicitly was the role of the implementation scientist in educating the IRB. because the IRB, different IRBs, different institutional review boards have different levels of familiarity with this work. Because we've been doing it for a while at the University of Pennsylvania, our IRBs are a little bit more comfortable with it, at least is my experience. And so the way we engage them may be a little different than for another IRB that's never heard of it before. So sort of at a meta level, if you can educate the IRB, you can sort of help yourself in the future as you're submitting these protocols. For Danielle, you talked about having aims with different approaches and that having implications for writing your IRB. So do you write it all as one big one, or do you write individual ones? And I think there can be some really strategic advantages to doing it as separate protocols, especially if some of the earlier work might be exempt, but certainly something we could talk through. Talked about hybrid effectiveness implementation studies, which Amanda also mentioned, but for sure, if you have co-primary outcomes, how do you think about that? How do you write about that in your protocols? And then you mentioned QI, which I love because oftentimes we're trying to get people to do evidence-based practices, and that feels like QI to a lot of IRBs. I think that's okay, right? If the IRB sees it as QI, I think that's probably fine. But you might write about it differently. You might engage with the IRB differently if they see it as QI versus research. So it's an important consideration. Both of you brought up issues around participatory and iterative approaches and how you manage that with the IRB. And then you also mentioned some issues around exempt versus expedited review. Often this work does not require full panel review, but in some institutions, I suppose it could. So just the types of IRB scrutiny that you're subject to are all important topics. So thank you for bringing all of those things up. I want to invite our audience members to put questions in the chat as they come up for you. But we did have a couple of questions that came in advance, and I certainly have questions for you all. Where do you start? Where do you start? Do you have templates? Do you like what? And what are like the questions that come to mind when you're sort of sitting down, you're like, oh, I got to engage with this IRB.
You want to go? So there's a generic template on the IRB website, which I downloaded as I was starting at Penn, because I'm newish to Penn, so did that. And then I read it and thought, so many of these sections do not apply at all to my studies because they're really clinical trial related in a lot of ways. And there's different options of templates you can use, but you pretty much are stuck with the clinical trial one, even though a lot of things in there don't apply. And then I reached out to my friends that have written protocols at Penn in implementation science before and said, will you share it with me? And then it would help me figure out which sections I should write in and where. So that's how I started. But it's not, the template is helpful and there are templates, but they don't always guide you for this type of research, at least in my experience, for everything that the IRB is looking for.
My answer to this question is maybe a little bit of a cheat, which is that I start with IRB office hours and finding somebody in the IRB who I can kind of partner with. Maybe it's an implementation strategy. There we go. We have like meta implementation science here. And thinking about how to describe what it is that we're doing and how to go about doing this, just in terms of saving everybody a little bit of time and effort. I found that to be helpful.
That's a brilliant strategy. I like that. I might have to steal that. I think, I hear the concept of steal like a sinner and share like a saint, right? So we're all learning from each other and all of that. So that's great. So we talked a little bit about the iterative issues around implementation mapping. And one of the questions that came in advance had to do with, it's a similar concept. How do you deal with qualitative instruments that might change? How do you deal with describing the analysis of open-ended data where you don't exactly know what you're going to be dealing with? Some of these iterative approaches are kind of baked into the science that we do. So how do you describe that, especially to an IRB that might be used to kind of a pre-specified protocol?
You wanna go first?
Sure. So I'll speak from the CHOP IRB side, which I know may differ from some of your experiences in the Penn IRB side. I think that I have had pretty good success with outlining the types of questions that may be asked without necessarily needing to provide full guides, interview or focus groups guides. And as long as they're able to see the types of conversations that will be had and the consent procedures that are associated with those, I haven't I haven't had a lot of challenges in moving that through and then submitting the guides later. Where I have hit snags is, and I like the approach that you were talking about, Megan, of listing all of the potential strategies that you may use. It's really more of that moving from the selection of strategies to the actual use of them. That's been more of a struggle for me, of that unknown.
Yeah, I mean, I have CHOP IRB experience that is similar in the sense that they required a lot of detail and actually split a protocol for a study I was working with someone else on, and wanted us to not submit the full protocol for the parts that were iterative until we knew exactly what every detail of that was going to be. I haven't had that experience with the Penn IRB with other research, so again, it varies. But my initial approach for both was to throw the book at it. This is my semi-structured interview guide. These are all the questions in every domain that I may ask. And then I write a nice paragraph about how I choose what I'm going to ask. And again, just talk about protecting subjects, and anyone can bow out at any time, and sort of just making sure it feels like a safe thing. And same with implementation mapping, give every strategy, but that was what hung up at least the CHOP IRB for one study that I worked on, where they were like, no, we need to know exactly the strategies and exactly how you're going to do them. So we had to break that aim off of the study, do the iterative work first, and then put it there. But it's hard because if they've never seen a research study with this type of data before, they can't imagine what it is. And so I think leaving as little to the imagination is a good strategy, but then sometimes too much information, and the side of my experience with CHOP, they got too much information, and then they were like, oh, but what if you asked this question at this time? Okay, I give up. So I don't know. I've done both approaches and been variably successful, so not sure.
Yeah, I think that concept of talking with the IRB, creating that dialogue, and I think having a very low threshold for reaching out, either by phone or by, video conference, to try to get in front of sticking points is really useful, because as much as we can share with you what we've experienced, it's not 100%, right? It sort of depends on who's reading your protocol, what their experience is, and it might just sail through, and it might not. Amanda, you brought up this point of breaking off pieces of the protocol. And I think, and Danielle, you brought that up too. It sounds like the IRB may have initiated that, but I think it's also something that is in the investigator's toolbox. If you note that there's a sticking point, you could potentially offer that to the IRB and say, I understand we're having some back and forth about this particular piece. Can we just break it apart, do this piece that is uncontroversial, have that go through, and then we'll come back and review this other piece. It could be a good approach.
Yeah, so I've done that, and then because I had to, but I've never done that by choice. And one thing I don't know, and maybe others know, is like, for example, for my Department of Defense grant, I don't think, because there's a separate human subjects approval from the Department of Defense once you've done your local one, and that takes some time. And I don't know that they would have been favorable of the idea of them not seeing all of it at one time. So that was an additional layer that made me very motivated to put it all together at once. So I don't know how funders really, depending on where the funding's coming from, feel about breaking up the human subjects approval, because I didn't have to do that for that one, but I imagine it would have raised a lot of eyebrows from their perspective, because they probably don't want to have to do that massive review that they do more than one time. I know other funders don't have that same criteria, but that would have been a bit of a challenge, I think, in that space. But otherwise, it's a good strategy, I think, because it does give digestible pieces to your science, and you can give as much information as you can each time, with a better likelihood of people understanding what you're doing and giving you the okay.
That's a really good point, that there are multiple stakeholders involved in this consideration of human subjects protections. And as much as we're anchoring on institutional review boards, the funders have a role in this that you've brought up that I think is really important. Community advisory boards may have a piece of this. And so how the approval process may look for those various stakeholders may differ. And so I don't know that there's a single answer to that, but sort of having that open dialogue is really important. I've seen through the NIH that sometimes they will ask you to kind of break things up as you're looking for approvals for things. I have a K mentee who is asked to submit different sort of pieces of approval for the different aims of their project. So you've seen one. And then we have a comment in the chat that yes, in the VA, it tends to be different. So Dr. Ashcraft, I don't know if you feel like you can say any more about that.
Yeah, certainly I'm happy to. I think especially VA funded work, they tend to they fund both quality improvement work, what they deem to be quality improvement work, which is work generally speaking, and again, I am not speaking on behalf of the VA IRB or the VA in any contextual way.
You do not represent the federal government.
Not in the least. My understanding is that the quality improvement work that exists within the VA is meant to be generalized within the VA context. Now, we realize that the VA is a national healthcare system, so that context is quite large, but again, the goal is generalizability within that context. And then there is also VA research work that they have a very arduous and painful IRB process for. However, what I will say is on the quality improvement side, which is where much of my VA research, quality improvement, implementation science work exists, there is a lot of flexibility. There is a lot of room to navigate that and to be flexible within that. The places where it gets challenging, and I think Amanda, you alluded to this, is doing any type of data collection with veterans, of course, is like a highly protected class. And so we are very cautious and thoughtful in the way that we engage that. And also with VA employees, there are union approvals that need to happen with that as well. And so I think, and I'd imagine there would be similar things if you were to do research within, say, for example, the Penn Medicine healthcare system or within another healthcare system. You know, the determinations could look a little different that way.
That's really helpful. Thank you. Can you all talk about how you think about pilot testing of instruments? So if you're thinking about qualitative research in particular, are you testing your instruments before you write the IRB, or are you building that in?
It sounds like we maybe have differing approaches. I've generally tested afterwards, and then if there are changes, coming back to the IRB. But it looks like, based on Amanda's nod, I'm not sure if it sounds like you've tested beforehand.
I've done both. I tip, like for an interview guide type instrument, I will have piloted that with folks before I submit that as the thing we're going to use for the IRB, just because if, like I said, I always do it like it's not going to be exempt. And then if we were going to change anything, you'd have to do the whole process of the change of that and approval and whatever. So just from like a workload standpoint, I try to do all that for the most part when I can first, but then there's times where you just can't. And so that's when I don't.
Yeah, I've done it both ways too. And our IRB on the Penn side, activities that are preparatory for research are not considered research. And so it's totally above board to do a pilot test. You can't then use those data. So that's one of the things that might push me one way or the other. If I have a limited population, like I'm going to actually use them up if I'm pilot testing with them, then I might get the IRB approval first so that I can still use their data even as I'm refining the instrument. And then I'll submit the final instrument as an amendment to the protocol. But I've definitely done it both ways. Can you all talk about the issues related to dealing with kids and caregivers? Like how do you explain implementation research to patients and families, given that often the targets of your strategies or the targets of your intervention are actually the clinicians that are providing services to the kiddos and the families?
Doesn't matter who goes first. I'll go first. I don't know. So I think implementation research is hard to explain to patients and families and children, you know, depending on how old they are. But it's kind of a strange thing to say, we're working on making your clinicians better at doing something. And we need your help and we want your feedback. And they're kind of like, wait a minute, they're not already doing the best they possibly can be doing for me, right? So there's some in my some work that I've done with children at CHOP that involves patients and families. It's a very delicate line to walk with them. However, like I've done some work in ED diagnosis space that was implementation science related, where we're trying to improve diagnostic care. And I do find that, like, you know, patients and families, children or adults, are excited about the idea that, you know, they know we don't always get diagnoses correct, and they would love to have their input shared with that. Now, when you think about the protocol, again, it's like, well, you have to talk about exactly what you're going to engage and what you're going to take from them, patients, children, families. And no, you know, usually we don't need identifying information, PHI, like any of that. It's more about engagement. It's that partnered research. It's their perspectives. So I talk a lot about perceptions and perspectives when I'm writing about implementation science. And I don't lump clinicians and patients and families together, but if children's perspectives are interesting, then I say we're going to gather children's perspectives. Or if we're gathering outcome data about children, it's aggregated, you know, de-identified data, not specific to or involving PHI, you know, for the most part, when I try to design studies that way, just so it's easier for people. But I use the word perceptions and perspectives a lot when I'm talking about the actual goal of the research. And that's our goal, is to change those things. So oftentimes we're just collecting those from different stakeholders, including children, patients, and families. And that's flown in the past from a protocol perspective for me. Don't know if you have different experience, Danielle.
Not different experiences. I really like and have had similar experiences in a lot of what you've said, especially considering how to explain things to families and using very plain language in my work. And the reasons that I talked about where my work lies is because there isn't even widely accepted terminology for what it is that we're doing in this space. Social care integration, social risk, social needs, like what does all of this mean? Utilities, when you're thinking about working with patient populations of caregivers and children, there's been a lot of work and also pilot testing of how we actually even introduce these concepts, which go into consent procedures and explaining what we're doing as well. So that's the only thing that I would add that's may vary by topic area. The other things that we've confronted in thinking about how to approach families are issues of consent. Most of the work that we've done has been working with consent of caregivers of pediatric patients who may or may not be their parents. And so thinking about what that caregiver role means and whether they are the appropriate people to participate and engage in this work and describe the work too. But then also what happens when the pediatric patients are over the age of 18. So we do see patients extending up into their 20s. Sometimes we get an occasional 50-year-old in CHOP with chronic medical problems who also have their adult medical team, but we are the people who know their part, let's say. And there's a lot of decision making and work with the IRB that ends up going into whether or not we approach those patients or pregnant adolescents. What does that mean for recruitment? Are these, if you're doing a population level study and implementation effort where you want to get wide-reaching perspectives and opinions and experiences, can you exclude these groups? Is it impractical to include them? And then what are all of the potential risks associated with involvement of these populations? So it's just maybe expanding the perspective of like, wow, pediatric patients can look really differently and they're not always kids in the way that we think of them.
That makes sense. One thing that you both have alluded to, but I want to make explicit, is thinking about the different types of consent that might be appropriate for an implementation study. And personally, I've used hybrid consent models where depending on if there are certain aspects of the project, I'll use a broadcast opt-out model where you just kind of tell everybody this is what we're doing. And if you have concerns, let us know. We've used that for observations in clinical settings where there are 1,000 or more eligible people to observe, and there's no way that we would be able to consent them all. Where we'll use a written informed consent for an interview, and then for some of the really technical inpatient stuff that my team does, we actually don't consent patients and families at all because they're not the target of our intervention. So we have a waiver of consent for them, although we do provide information in case people have questions about what we're doing. So I'm curious if you all have used or thought about these sort of hybrid consent models and how that's come up in your work.
Yeah, I haven't used the hybrid model, and I've heard you talk about it a few times now, and I kind of wish I had thought of that before and maybe I still will for this piece of my science that's similar to yours, where like patients and the families are, in my case, going to get or not have a clinician use telemedicine, telementoring to help take care of them. We're not going to talk to the patients and families, and the clinicians are individually consenting to tell us about whether they're going to use telemedicine or not. But the idea that everybody here is going to use telemedicine when available is sort of just the standard of care argument. And so there is no opt-out if you don't want to be involved in that. And that was something that no IRB had concerns about. But the more that you talk about it, I think probably the more ethical way to go would be to allow some folks to opt out on that particular thing. It would be tricky though, because you've got teams of 10 or 20 people in the room every time. And can you really have that one person, leave, and then everyone's going to know that they've left and why did they leave? And then there's coercion that could happen. So short answer is I haven't done it, but I totally see the use. I think it could be really helpful for exactly what you're talking about when there's pieces of a thing that some people may not want to do, and it's reasonable that they could opt out. But unfortunately, I think for this study that I've got, it would be really hard for clinicians to be like, oh, I'm just kidding. I know all of the patients are going to get this, but none of mine are. And it's like, people will be wondering why you're using it all the time, but not when that person's in the room. It could be a little bit off.
It's a good point. And I think the coercion piece is something you have to think about. One of the things so in our study, the clinicians can't opt out of the thing we're trying to get them to do, which is communicating in a structured way, but they can opt out of being observed. But to make that distinction, because in order to do this, we have to get the clinical settings to agree to a new standard of care. And so everyone is supposed to be signing on to that piece. But you're right, if there are pieces where if someone opt out, it would actually be more noticeable, then that's not really a viable option. But Danielle, I'm curious if this has come up at all for you.
It hasn't. It's coming up in some of my thought process about this current proposal that I was just talking about, but I'm really enjoying this conversation and very interested in learning more.
That makes sense. So we had a pre-submitted question about single IRB determinations, and Amanda, you alluded to the idea that funders are increasingly expecting this, but what roles have you all had in determining whether a single IRB is appropriate, and can you kind of talk through some of your experience in navigating that process?
I mean, I think a single IRB, I've yet to get one on any of my studies because like I said, if it's exempt, at least the Penn IRB won't do that. But it would be amazing if it could be, because individual IRBs for all the sites in a thing, especially if you're looking to test things in different systems, different rural and urban and all kinds of places, which is what I'm doing in this telemedicine study. A single IRB would be so great from a study efficiency perspective, and honestly, from an IRB sophistication perspective. I really would like an IRB who understands this research to be the ones who weigh in on, is this protecting the people in the research? And I find that especially I've got a lot of rural hospitals like in northern North Dakota and other places that don't do research very often, but would require an IRB to be part of the approval, and their local IRB just isn't as savvy. And I trust that we're not doing anything wrong, and that all of those things are on the up and up, but also I don't know that they they have the benefit of that same knowledge at the local level. So I think the idea of single IRB is great. I just think it's a challenge with exempt studies. And I almost wish that it wasn't, but then there's a whole bunch of stuff that comes with not being exempt that I probably am happy that I don't have to do. So I think it would be amazing. And I actually wish the Penn IRB would do it for an exempt study, especially in circumstances like this where you got a multi-site research study and it's just really hard to get everybody's IRB on the same page.
So yeah, Laura Ellen asked that question in the chat. I don't know if it's just a Penn thing. My multi-site trial thankfully is, or I guess thankfully, is expedited. And so we do have a single IRB. It was relatively straightforward to say to the individual sites, this is an NIH requirement. And so if you're going to sign on, this has to be part of it. And so then when we got funded, we could go back to the sites and say, remember? And so then they could, we submitted it to the Penn IRB, we got our approvals, and then we submitted it to the rest of their IRBs for reliance agreements. So we came up with customized forms, customized versions of all the consent forms, for instance. So all the consent forms had the site PI's name on them and the local IRB number, but there wasn't the sort of full review each time. And then another thing that Penn's IRB does that I really like, that I think is a little unusual, is for an expedited protocol, you only get reviewed once. And so you don't have the annual continuing review. And so every year I get an email from them that says, remember, you're still good. And I go, great. And so we send that to the rest of the sites. And then it just keeps going. And I think that's how it's supposed to work, but it doesn't always work that way. But Danielle, what's your experience?
I think that it's a phenomenal idea. All of my work has so far been exempt. Yay. Ooh, I'm not sure in the context of this conversation. But I agree with you. And I'm glad that this question was asked because I feel like it launches into a whole nother line of questioning, which maybe I'll pose back at both of you as well, which is that we've talked a lot about the varying levels of understanding of implementation research by IRBs, but also in doing these multi-site implementation or hybrid trials, there's varying levels of understanding at the site PI level. So in thinking about, this is another challenge that we've had, is just supporting the sites as well in communicating with their own IRBs when a central IRB cannot be used.
Yeah, I mean, I had a site PI because in some places IRBs allow site PIs to determine exempt status and not even submit something to the IRB. At a site PI determined something was exempt, and then another person that works in that place didn't feel it should be, alerted the IRB, and then after the fact we had to go and do the full submission with them, pause data collection at that site and whatever. And it was mostly because the site PI thought it was QI, and in their place, QI is, you don't even need to bother telling the IRB about QI. And it ended up being exempt in that place after the full IRB looked at it. But it was a good example of what you're talking about, which is not everybody knows all the nuances, and especially at the site PI level, could explain it honestly in either way, and sometimes like, oh, this is just like quality improvement. And then they could reassure themselves that way, write it up that way, and they would fly that way. But as the person leading the research, I feel an obligation to make sure that everybody really understands what they're getting into. And without the single IRB structure, I can't write back to their IRB as an outside person and be like, oh, by the way, you actually probably want to look this over. Like I wouldn't do that anyway, but you know what I mean? So it is a bit of an ethical dilemma, I think.
Yeah, I agree with what Amanda said. And I try to give the site PIs as much insight and guidance as I can, whether it's putting together short PowerPoint decks about the protocol or putting together a one-pager. The one-pager is golden, right? Because they can share it with almost anybody and it's just a quick distillation of what the project is about. But I've also met with IRBs. So one of our sites, it is a Penn site, but they don't have the same IRB. And so I met virtually with their IRB to say, let me explain this to you. And so offering that, even if you're not based at that site, you could, join and for 5 minutes talk through the protocol. But I never assume that people understand it at the same level that I do, because I have time to think about these things, and site PIs are often very busy, and so just try to make it as easy as possible for them. I will say about the single IRB thing, there are IRBs that are sort of disembodied from academic institutions that you can pay and partner with to do reviews. And I don't know if that's a potential mechanism to get that SIRB if your institution won't do it for an exempt study, but it's potentially something worth looking into because it would streamline the work.
Yeah, another thing about single IRBs that I didn't know when I proposed it is that it's also expensive. From a budget perspective, if you have a single IRB, your single IRB charges per site in a different way. You've got a budget for certain, like for the execution of the agreement, and then also continuing reviews and how they happen. So I am kind of intrigued by the idea of an external one, and maybe they would just charge a fee that's very grant budget friendly, and it would just kind of, because certain sites have different varying costs for their IRB. And so it was actually hard to write the budget. Thank gosh, I don't have to use it, but also the budgeting for the single IRB was tricky. I don't know if you've come across that, but each site has to have a separate budget for different parts of the reliance agreements and continuing review and all the things. So if there's an external, it'd be great. And if they could actually be used to that kind of thing and have a structure, funding structure, I could see that as a big advantage too.
That sounds good. Yeah, I have not, I'm not familiar with that, but I'm glad you brought up the budget issues because that is something that needs to be considered in writing the proposals and getting funding. Yeah. So we're nearing the top of the hour, so I'll bring us to a close. It's been a wonderful discussion about the IRB, the favorite topic, everyone's favorite topic, right, in research. But I'm very grateful to both of you for sharing your insights, and hopefully for the Amethyst crew and the Amethyst family, the larger Improve initiative, and anyone else who's watching, you've taken a little bit away from this experience. We'll be posting a recording at some point soon and look forward to seeing you next month. Thanks, everybody. Have a great weekend.
Thanks so much.